Ladies and gentlemen and audience online, I would like to welcome you to this lunch session sponsored by B. Braun. It's called DCB DES scaffolds, one fits all or all fit together. I'm still missing my colleagues in this panel. My name is Tuomas Rissanen. I come from Joensuu, Finland, and it has been a great sessions here to see the really advent of drug-coated balloon. We have had very nice case sessions, and also scientific data has been shown. I would like to start with my own presentation. It's called High Bleeding Risk Patients, Polymer-Free Treatment Options with DCB and DES. These are my disclosures regarding this presentation. I would like to start with a patient case. This old gentleman was presenting NSTEMI, and the other clinical problem was ongoing hematuria. Coronary angiogram showed diffusely diseased LAD with eccentric plaque in the proximal part, and then subtotal occlusion in the mid LAD. This was uncrossable to normal small balloons. So we performed rotablation. The more distal lesion was treated with 1.25 BER, and then the more proximal LAD with 1.75 BER. Thereafter, lesions were pre-dilated with NC 2.5 and 3.0 balloons, and two long drug-coated paclitaxel balloons were applied. This is the initial final result, and what was remarkable was that only aspirin and low molecular weight heparin was used in this PCI, and only aspirin thereafter. No P2Y12 inhibitor was given at any time to this patient. The patient came back for diagnostic or sort of control angio 5 years ago, 5 years after the index PCI because of dyspnea, and you can appreciate positive remodeling and vessel growth in the treated LAD. The diagonal was left to medical therapy at this point. So why bleeding is important in contemporary cath lab? We know already from several randomized controlled trials done in HPR patients that the bleeding risk is about from 10 to 15% at 1 year. And what is not, I think, very widely known is that up to 40% of patients undergoing PCI in a real-world scenario have at least one ARC bleeding risk factor. And if bleeding occurs after PCI, it's associated with very highly increased mortality, increases healthcare costs, and prolongs hospital stay. So how do we assess bleeding risk? A few years ago, the ARC criteria were published, and this is very important for every interventional cardiologist to know these, and they are also available online and in the app stores. We have the major criteria on the left side and the minor criteria on the right side, and one major or two minor criteria are required to have a bleeding risk patient. These criteria have been validated in a real-world PCI population, first in a Japanese cohort. And on the left side, you can see that the patients at bleeding risk have a 10% risk of bleeding at 1 year, and in comparison to only 3% in patients that do not have elevated bleeding risk. And which is also clinically very important is that the same patients that are at bleeding risk, they also have elevated risk of ischemic events. In this population, 43% had at least one major or two minor criteria for bleeding. which is also important for a clinician is to realize that the components of the criteria are not the same, but thrombocythemia and especially both severe kidney disease and as well as moderate kidney disease are distinguished here to increase the bleeding risk more than, for example, oral anticoagulation. The criteria were also validated in European population, which was from Bern, and you can see the threshold of 4%, which is considered to distinguish between the non-HPR patients and HPR patients. And as the score accumulates, also the bleeding events as well as the ischemic events increase. In this population, 39% of the patients were considered to be at high bleeding risk. So what do we know about stents in these patients? We have already many randomized trials testing stents in HPR patients. The first one was the leaders-free trial, where polymer-free biolumus-eluting drug-eluting stent was tested against BMS. Thereafter, senior trial tested biodegradable polymer everolimus synergy stent against BMS in older patients. And then also, which is I think quite remarkable, was that Onyx 1 trial showed that also durable polymer sotarilmus stent allows 1 month DAPT, and all studies showed quite low risk of stent thrombosis. The largest study so far was the MasterDAP trial, which had over 4,000 patients and randomized either to single antiplatelet therapy or dual antiplatelet therapy after 1 month of DAPT. The patients were old, and 1/3 was on anticoagulation and half were having ACS. And the trial used biodegradable polymer sirolimus-eluting DES. There was no difference in the ischemic endpoints between the abbreviated DAPT and standard DAPT, but most importantly, there was about 30% difference in major or clinically relevant non-major bleedings between the groups. And on the safety side, it is very good to know that the stent thrombosis risk was not elevated significantly in the 1 month DAPT group. A meta-analysis showed that also after complex PCI, abbreviated DAPT is non-inferior to longer DAPT in terms of ischemic events on the upper row, but the abbreviated DAPT leads to about 50% reduction in bleeding events. So stents do work, but they are not still the optimal treatment. I think the current generation drug-eluting stents have accumulating event rate, and this is about 3% after the first year, ending about 40% during 10 years. So then we come to the question whether DCB could be a solution in HPR patients. In the same meeting 4 years ago, we presented data on the landmark study on DCB in high bleeding risk patients. And this was a trial which randomized HPR patients after successful predilation in all-comers population, ACS and stable patients, either to paclitaxel-coated DCB or BMS. And you can appreciate that the mean diameter of the vessels were 3 millimeters and only 2% rate of bailout stenting with BMS after successful predilation and DCB treatment. The dual antiplatelet treatment was similar between the groups. This is the primary endpoint of the trial, which was MACE at 9 months, but the difference between groups sustained at least to 3 years, and the MACE rate was significantly lower in the DCB-only treated group as compared to BMS. And unfortunately, BMS was the standard of treatment when we started this trial almost 10 years ago. Very importantly, no acute closures occurred after DCB treatment. The Basket Small 2 trial was the landmark study for small vessels, and it had a significant proportion, about 20% of high bleeding risk patients, and this was a pre-specified subgroup analysis. And interestingly, there was a trend towards lower significant and severe bleedings in the DCB group as compared to DES group. And I think this is due to the shorter DAPT duration in stable patients as compared to DES group. There was no difference in the MACE rate between the groups. But then I would like to move forward to a new concept, which is single antiplatelet treatment in HBR patients treated with PCI. So as we all know, dual antiplatelet therapy was initially developed for prevention of stent thrombosis, and our hypothesis was that the lack of permanent metallic coronary implant could allow omitting dual antiplatelet therapy in these patients. And we studied this approach in a single center registry. We included 232 PCIs in 172 patients. All patients almost all had bleeding risk. 60% ACS, almost all lesions were de novo, and large arteries complex lesions. Half of the patients had peri-procedural dual antiplatelet therapy, but all patients were sent home on single antiplatelet therapy. And I think remarkably, Kangrel infusion was used in 23% of cases. Most of the patients were sent home on aspirin or clopidogrel, and fewer with more potent P2Y12 inhibitors. And in anticoagulated patients, the single antiplatelet treatment was mostly 3 months or less, and some were sent home without any antiplatelet drug. This is the MACE on the left side. We divided the population on patients on anticoagulation or no anticoagulation. There was no difference in the MACE rate, which was acceptable, 7% at 1 year, considering the very sick population. There were no acute vessel closures, TL rate was low, and also the bleeding rate was quite low, 10% in the overall population. Also, my colleague here, Dr. Cortes, they have also done similar research. They had 100 patients, 71 years mean age. Most of the patients had anemia, active malignancy in 20%, and kidney disease 42%, and some ACS patients. And I think it was remarkable. They reported that A and B type dissections were left in half of the cases. The procedural success rate was very high, and the patients were sent on either aspirin or clopidogrel. And the 12 months rates of TLR and MACE were low. Mortality was quite considerable, but these are very, very sick patients. But we need randomized data, and the debate trial hopefully offers it. It's now going in Finland, and in some other European countries are joining. And we randomize de novo lesions in patients with HBR after successful predilation, either to paclitaxel-coated DCB or current generation DES with CMARC for 1 month DAPT. And which is important, there will be different antiplatelet regimen between the groups. And the primary endpoint is the NACE net clinical outcomes, a composite of ischemic and bleeding episodes. I would like to finalize my presentation with a patient case. This is a young fellow with type 1 diabetes and severe moderate to severe hemophilia. He presented with unstable angina, and angio showed tight stenosis in the mid part and some disease also in the proximal LAD. There was a strong recommendation not to use P2Y 12 inhibitors in this patient. So we performed LAD PCI using no P2 12 inhibitors, only aspirin and enoxaparin, cutting balloon followed by paclitaxel-coated DCB. This is the initial result showing some dissection but normal flow, no pain, no ECG changes, and the patient was discharged. 5 years later, the patient came back. He had poor compliance to lipid-lowering therapy and was still occasionally smoking, but you can see that the DCB-treated part of the LAD has healed. There's some progression of disease in the proximal part, which was treated after FFR measurement. At this time, we used perioperative gangrel infusion to have good platelet inhibition. And this is the final result, and the patient has been asymptomatic for 3 years. So I would like to conclude my presentation that up to 40% of contemporary patients have bleeding risk in the cath lab. Bleeding is associated with highly increased mortality. 1 month DAPD is possible after modern DES, irrespective if they have durable or biodegradable polymer or even polymer-free. But I would like to impress that DCB-only approach seems a promising new strategy and could be combined with single anti-platelet therapy, but this has to be shown. Thank you.
Thank you, Thomas. Very, very nice presentation. First point, you should not feel alone anymore because we are here with you. Thank you for taking the lead of this very, very interesting and complete, I would say, session. I have just a short comment. I don't know if also the audience would like to speak, but we are here open to reply, and Thomas is open to reply to all of the questions. The point is that high bleeding risk patients are patients where we should not focalize only on the high bleeding risk, so DAPT, we should interrupt, then start again, whatever. We should focalize on the other point that you underlined, which is that these patients are at high thrombotic risk. And stents are associated, we have seen it clearly with the Onyx 1 2-year data, with a high thrombotic risk, not only in terms of thrombosis, stent thrombosis, but also of MACE overall, with an 18 to 19% in both groups of events at 2 years. So in this setting, DCB is really a fascinating strategy.
Yeah, I agree totally, because the lack of metal is, I think, beneficial for the patient. And I think that the DAPT must be tailored according to the patient, medical history, lab values and everything. But there are cases that we must implant stents. Yeah. And we know from the Solution de Novo trial that it's about 17% that we must implant a stent so that we cannot treat the lesion with DCB only strategy. And we in some cases must combine stenting with DCB to reduce the stent length and hopefully reduce the ischemic events in the long term.
Yeah, correct.
Yes, very interesting presentation, very nicely done. You were talking about in your last sentence about the hybrid approach of stenting lesions that we have to stent because of acute recoil or heavily dissection with flow limitation. How is that in your practice? You showed a very nice case with DCB only. What is the percentage, if you can say, of the hybrid approach?
I think the most important thing is to be open-minded when you start your procedure. You can plan the procedure, you must plan the procedure, use physiology and imaging, but then you start predilating the lesions. And of course, it's only after the predilatation that you can judge whether you can use DCB-only approach or you should stent, or then you should use the hybrid procedure. So you have to be open-minded, and quite often the strategy a little bit changes after peridilation of the lesions. And of course, if you treat many lesions, many vessels, the risk of stenting one vessel accumulates, and it could be important, especially in the bleeding risk patients. But I think the message, what I would like to say is that a reduction of stent length is I think, the goal that we should go forward with DCB only.
In the basketball, we had the limitation of below 3 millimeters, and we also had very clear definition on what dissections could be left behind and when do we have to stent. How is that in your daily practice? I see you now treating bigger vessels, 3.5, 4.0. Yeah. Is there a difference? Well,
we stick to the international consensus group guidelines, so that the flow must be Timi3. I don't grade these sections myself from A to F types. I visually inspect the flow. I ask the patient whether he or she has chest pain. The problem is that the chest pain is there quite often after long inflations, but it should diminish during the next few minutes. And then also there should not be any ECG changes. And there, if these 3 parameters are okay, I will leave the vessel alone. And of course, you have to judge also the recoil aspect, because recoil is more important for restenosis, and the dissections might be more important for acute closure.
Yeah, I would like to add something, Gregor, to this point. We had recently, 2 days ago, during the ARC DCB meeting, long discussions in which should be the final person stenosis that we should leave after a DCB PCI. I think that in the easy lesion setting, 30%, like it was already suggested by the several consensus papers, should be left. But if we want to avoid excessive stentings in the multi-vessel disease, very long lesions, highly calcific lesions, where we are gathering a good experience with DCB, in this case, we can also leave some 50%, up to maximum 50% person final stenosis. Also, because we have understood that treating a restenosis after a DCB is easier than treating a restenosis after a drug-eluting stent. So DCB is perdoning more. So 30% cutoff can be good, but in an extensive diffuse disease, also 50% maximum can be achieved.
Diameter stenosis.
Yeah.
And for sake of time, I'm not opening up the issue of imaging, because MSA and how do you would that call after DCB, MDA, mean DCB area or something of the stent. It's probably coming in the future, and we will see a lot of changes. So thank you very much. Apologize for my late event. I was caught up in another session. I couldn't get out, so sorry about that, and thanks for starting. I think it's now my pleasure to introduce Bernardo Cortesi, the man that doesn't need an introduction, but I just still want to introduce your title, which is DCB in the Rise in Daily Cath Lab Routine.
Thank you, Gregor. While the presentation is uploading, I would like to, if it's uploading, but I uploaded it actually, the picture is there. I would like to make one point, which is an important point. This year at EuroPCR, DCB, also thanks to B. Brown that organized this meeting, are having a great, it's coming back, a great momentum. However, still we see live cases here at EuroPCR, like yesterday, 2 live cases with extensive stenting. So I hope that in the next future, maybe also next year, this will be reduced a little bit. Maybe putting a stent in the proximal segment and all of the rest, like Thomas was saying, managed by means of DCB. So this I would like to see not only in this symposia, which is really packed, but also during live cases. So that said, let's start from, we need to push and to kick somebody. Here we do with the stents, we use stents in many cases, obviously, but we still have to remind that in the complex lesion setting, stents are not a perfect tool, and still we are paying a gap versus cabbage. Okay, so these are the FAME3 data. At 1 year, we will see the longer follow-up, but the non-inferiority here in this trial was not achieved. So mostly due to recurrences, and we have to remind this. And probably one of the reasons is related to the technology itself, even if we have very good stents outside. We have seen the 10-year follow-up of ISAR test by Thomas. We also have some other 10-year follow-up, very, very long follow-up. Unfortunately, so far, we don't have so long follow-up after DCB, but stents in the complex lesion setting, which is the same, a routine lesion setting, are not a perfect tool. The more, for example, in the calcific lesion setting, the more the calcific the lesion is, the worse is the outcome. And it is quite the same also for very long lesions, more than 40 millimeters, and for the small vessel disease setting. So these are becoming quite routine cases that we do every day, at least 1 or 2 cases per day like this. And we have to remind that stents were not analyzed in this setting in the pivotal randomized clinical trials. If we go with long follow-up, we can see what is happening. On the contrary, I like to present this slide quite often. The concept of DCB is totally different. We don't implant a prosthesis, hopefully, but we put the drug which should act for the time where it is needed in order to counteract to this initial smooth muscle cell proliferation and also the initial reclutation of the EPC from the blood. We have some differences between sirolimus and paclitaxel, but they both act in the same direction, blocking this, and then also blocking the next step, which is happening if you put a prosthesis, if you put something, a foreign body, for the following time. So this is the concept of DCB, which has been clearly shown and demonstrated by this study from Franz Kleber, which showed how paclitaxel is able to create and to determine a lumen enlargement. And this is a very fascinating thing that also with the BVS we try to understand. Now, later you will tell us something, but DCB for sure are the best tool, paclitaxel DCB, to show this. And the other concept, which is quite interesting, shown by this study by Yamamoto, is that the more you dissect within the type A, B, or sometimes C dissection, the better is for, again, in this case, paclitaxel to enter the vessel wall and to exert a good activity in terms of reduction of the angiographic outcome. And we have also seen a few years ago that leaving a dissection type A and B is not a big issue with DCB. In this consecutive series of patients with native vessel disease, mostly small vessels in this case, we have rechecked again after 6 months the patients, and we have seen that the dissections did heal, except for 3 cases, but we had 0 cases of acute or subacute occlusions during the follow-up, also the subsequent follow-up, clinical one, up to 1 year. So only 3 cases of chronicized dissections, but 0 cases of acute occlusion. So it is safe to leave a dissection after a DCB. Clinical data, we have the 3-year follow-up of basket small 2. On the left, no differences in terms of MACE as compared to drug-eluting stent. And also, if we compare directly the sequent please with the Xiant, with the everolimus eluting stent, we can see that they are taking out bailout stenting, which should be avoided unless necessary. And also the Taxus patients, which were enrolled at the beginning of the study, the performance between these 2 top-in-class devices is very similar at 3 years. Then we also have, I cannot avoid to mention the good performance also of other paclitaxel-coated balloons. Here in Piccoletto 2, we were able to show the superiority of this technology versus everolimus-eluting stent in the small vessel disease setting. But very interesting and recent data. We have the 3-year follow-up, and for the first time we have shown how there is a reduction in terms of MACE in this smaller than basket small 2 setting, lesion setting data, mostly related to lower acute occlusion of the vessels. You know, this study is small, it's a mechanistic study, but this information is quite reassuring. Mostly if we take a look at the stop of the events in the DCB group after 15 months. Then just to avoid boring you too much, I put this case. I already presented it, but I think it's a didactical case. We had this nice, I would say not so nice, calcific nodule at the ostium of the LAD. We suggest to use intravascular imaging, either IVUS or OCT, whatever you prefer, in the highly calcific and complex lesions. So we tried to manage it with shockwave, but we were not able to cross with the balloon. So we predilated. It takes time, okay? Also for stenting, obviously, in order to achieve a good lesion preparation in a complex lesion setting. So we went with ROTA, with a small bar, 1.5, then we predilated, and in the end we used intravascular lithotripsy, and then we assessed the outcome, okay? 2 orthogonal views, we had a good lesion preparation, so at this time we can decide if to put a stent, if still we are not sure, or if to use a DCB. You may imagine what we decided to do. We used 2 DCBs in the ostium and in the proximal part of the vessel, then we reassess it. Good outcome. In this case, I promise you, we left much worse cases treated with DCB, still with a good outcome. This was good. 2 orthogonal views, you wait for a few minutes, and then you are done. And we also have a good angiographic result after 11 months in these patients. I will skip this because already Thomas has underlined the not persistent thrombotic risk associated with drug-coated balloons. So in a highly selected population of 107 patients, we wanted to see how the performance of a single antiplatelet therapy since the very beginning of PCI was. And Thomas has already shown that at 1 year, the MACE were very similar to the de novo population in 2,000 patients with lower bleedings. So this is a fascinating information that need to be confirmed by the study that Thomas is running. And then also Thomas went through another important topic. We cannot think to treat all with DCB. We have this very good data from the Southeast where they propensity matched to prospective databases showing which is if there is a difference between a full drug-eluting stent in a multivessel disease approach versus a blended therapy. And importantly, in the blended therapy for 2/3 of the lesion length, a DCB was used, and this DES was used only proximally. Data are really fascinating, in my opinion, showing again the flattening of the curve of the events up to 2 years of follow-up with a significantly reduced MACE. I don't want to comment on the reduction in cardiac death because maybe it's a play of chance, but the MACE are significantly reduced in the blended therapy. Then we have sirolimus. We cannot avoid mentioning this very fascinating and fashion also drug, I would say. We have 3 devices on the market. Only 2 of them have clinical data so far to present. We have the B Brown one, which is showing the non-inferiority as compared to Sequent Please in the de novo setting with a quite reassuring and good angiographic performance at 600 follow-up. And then we have the data from another sirolimus-coated balloon. We are going to present a 2-year outcome of the ISPON registry today to see how is the efficacy and the safety of this device in a broad clinical population. But the 1-year follow-up, which has been recently accepted for publication, is showing a very good outcome in terms of TLR in the de novo population and 10.5% of TLR in the ISR population, which is quite similar to other paclitaxel-coated balloon in this lesion setting, I have to admit that only 10% of the patients underwent intravascular imaging. But this is a registry, real life, so we couldn't force physicians to use intravascular imaging. This is my last slide showing how the field is rich in terms of randomized clinical trials in very different lesion settings. I became aware during EuroPCR of other 3 randomized clinical trials starting to enroll patients soon, hopefully. So the field is very interesting and rich in this new era for interventional cardiology. So my conclusion, DES are good, okay, but they are not perfect. We have to remind this very well because we have still the risk of very long-term outcome, which is not always good. DCB are a valuable tool for the daily armamentarium of the cath lab. You should have at least one good DCB in your cath lab. You should choose it according to your experience. You may decide to use a paclitaxel, sirolimus, according to the data, your choice, but have it, know it, and rely on the preclinical program and on the clinical program of that device. Currently ongoing trials will give obviously more fuel and more information about the performance of this technology. Thank you. I can come back.
Yeah, thank you very much for this elegant talk and overview. I was just thinking on your last slide, DCB and multivessel disease. We all believe DCB is a game changer, but I think this will change even how we treat patients long-term in terms of heart team and bypass graft, I think. Do you believe that there has to be a new syntax score for DCB patients? And do you think that this will put even more stress on the surgeons? And can we compete with them even more with DCB solutions?
For sure. I remember discussing with our surgeons a few years ago when they said, okay, this patient should be the fight, normal fight for a three-vessel disease patient, surgery or PCI. Surgeons said in more than one cases, well, we have stents. We know that you are going to have in this diffuse disease, stent thrombosis and recurrences. And they said, well, let's use a DCB so we can spare it. And he was smiling. DCB, what is DCB? But he was right. Because at that time, but still now, we don't have data. So this is why I'm pushing with some companies in order to have a good study versus CABG in the diffuse disease. Why not? We have seen what's happening with FAME3. It was a very perfectly done, experienced centers, physiology, all of it, but still we are not able to cover the gap at 1 year. Then on the long term, we will see. We have seen in Excel what's happening and whatever. So why shouldn't we program a study versus CABG in the diffuse disease?
I would like to ask you, what is your preferred drug on drug-coated balloon? How do you decide whether to use paclitaxel or Limus-based technology?
Well, the Limus-based technologies have an advantage, two advantages. One is that they are better perceived by the population of interventional cardiologists, according to the fact that all DES have Limus, and they are quite the same. And the second one is that deliverability is higher. So this is something that is not easily measurable with the clinical trials, but the physicians that have to face with complex cases, calcific lesions, tortuous vessels, need to have a deliverable device. So these are two advantages. On the other hand, we have a great experience with paclitaxel and only a limited initial experience with sirolimus. So interesting data, but we need still to analyze it. Gregor.
Great, thank you very much.
Your turn.
So I'm going retrograde a little bit. So this is the talk, initial. I was usually to start, so it's about DCB, DES and BRS, and BRS is now my topic. And the question of today is one fits all or all fit together. I think it's the second one. It's usually a combination. As said before, some cases need scaffolding. So I think we're all agree on that. And I want to present you a new scaffold, which I believe has a great potential and can take a lot of the load of the vessels that need to be scaffolded. So this is my session objective, basically. We all know stents have improved, the alloy, the design, the coating, but they're not yet perfect. They're near perfect, but not yet perfect, as shown. Imaging makes it a better stent, so imaging is advisable there. And my question was answered, is it also advisable in DCB? Therefore, we need more trials. In-stent restenosis, stent thrombosis, neoatherosclerosis, these are all very bad things because it's difficult to deal with. As stent thrombosis, you cannot deal with because by the time the patient comes into your lab, a lot of the myocardium is already at risk or died. Neoatherosclerosis is very difficult to treat because you have calcium on both sides of the stent, and these are things we can hopefully avoid. Absorb story, just one slide that I'm going to show you in a minute. The DCB technology has been shown. I'm not going to talk about the magnesium scaffold, and what I want to show you is the ThyroCore. That's a new polymer, and this on the right side is how I see the future. I think the vast majority of our patients and lesions will be treated with DCB, hopefully. A lot can then bailed out with bioresorbable scaffolds, and for very tough situations and maybe left main bifurcation due to overexpansion capacities, we have to still stent. So these are the previous talkers, and this is the disadvantages. It has been talked about. We all think that the stent will solve the problem, give us a nice lumen gain, and then that will stay forever. But you can actually see that there is a lot of sequelae that are deleterious that can cause. We can have late acquired malapposition, stent thrombosis risk, neoatherosclerosis, neointima hyperplasia, in-stent restenosis, and also delayed healing with inflammation. And this is all only avoided if we avoid implanting the stent initially. Old versus contemporary DES didn't change much. You can see that paclitaxel is not good on a stent, maybe on a balloon, but the Limus drug is better, but still we remain with this 2% annual risk of MACE. This is also true in a landmark analysis, so it keeps going until the stent is removed, and this is an irreversible and impossible process. So avoiding all these complications is only done by not putting the stent in. People thought sometimes we need a stent, and it would be nice if that stent then removes itself, so it absorbs, and Absorb was the early PLLA scaffold on the market. It was very hyped, and then also the downfall was abrupt, and in my opinion, a sad continuation of this hopeful story. So it worked initially, but in small vessel exclusively, especially, we had all these problems that we have with stents as well. And absorption is not something that is just like melting butter in the sun or wax. It's an active process of inflammation, and inflammation shown by Dr. Cortisi before is something we don't want to have in the vessel. So here against their own DES, the company could show a late benefit, although I said the resorption does create inflammation, but you can see that initially the MACE rate was equipoised to the metal scaffold, and after 3 years, when the resorption should have been over or starts, there is no more events. So early hazard, late benefit is the idea, but it didn't pan out, and you all know the GHOST registry that could show increased stent thrombosis, and then eventually led to the death of this Absorb scaffold on the market. The pathophysiology behind is not only absorption, inflammation, but it's also strut thickness and turbulences, and that was the initial problem of the scaffold. It needed thicker strut in order to achieve as much radial strength as DES, and you all know the guidelines, and in my opinion, they are not considering all aspects. They're only considering Absorb, and I want to show you in the next 10 minutes what is different in Absorb to ThyroCore and why I think ThyroCore is an improved scaffold over PLLA. These are the scaffolds that were on the market at one point, and only remaining is the magnesium-based scaffold and this Phantom. Not going to talk about the magnesium. I think it's biologically a different animal, and today I only want to show you the evolution of the ThyroCore. It's actually a very old scaffold, initiated in 2012, so over 12 years, and it evolved in the design and polymer optimization and strut thicknesses over time. And now we're having the latest Phantom Encore scaffold, having strut thicknesses around 100 micron, which we believe that it's biologically accepted compared to older scaffolds, as you can see here, that are almost 50% thicker. ThyroCore is first generation BRS polymer, and its bioresorbable characteristics are unique. And this is something I want to show you in a little bit more technical aspects now. So it's a composition of iodinated diphenol of a tyrosine amino acid that you know well. And the amino groups on the side are substituted for iodines. So you have 4 iodines here, and that causes radiopacity. So it's actually visible as a DES, and that facilitates a lot your work and also improves optimization and therefore outcome. This ThyroCore is also biocompatible, of course, and it resorbs without or with less inflammation than PLLA. It's a strong polycarbonate phenol ring, so it's a really heavy polymer, and it also has an improved ductility, so improving mechanical aspects of your implantation. Here you can see tensile strength compared to PLLA is doubled, and the elongation, so overexpansion capacity, is more than 50 times of an absorb stent. And you can also here appreciate the radiopacity. That's the absorb with the 2 markers. This is the Phantom ThyroCore scaffold, and that's a regular DES. And you can really appreciate how well visible this scaffold is. This is an image from my lab with ClearStent Live, and I think you could not distinguish the scaffold from DES in this image. And you can actually see how you can optimize and even see stent distortions that potentially need to be corrected. The Phantom has improved the performance. Again, the Encore has 33% thinner struts than any other scaffold that has been put on the market. The radial strength is 1.5 of the absorb, and the recoil is also very low. It's in the range of a normal DES. So you see that scaffold has very DES-like behavior. This is radial force, which is even higher compared to a DES. And you also see the characteristics of the polymer. It's a little stiffer. That's with all polymers. You can see it with absorb, but it's actually really high, and it's comparable to a drug-eluting stent. Longitudinal compression, also important at osteolesions and bifurcations, is equal and enough high to a DES. So this is not a risk of compressing the Phantom. And lateral flexibility is also in the realm of all the other scaffolds. So it's a flexible, trackable, deliverable scaffold with high radial strength. Very interesting, not only the radiopacity is facilitating your implantation, but also the implantation steps. You might remember the absorb. You have to go up 2 millimeters of 2 atmospheres every 10 seconds. And if you go to 15, it takes forever. With Phantom, you can just implant it like a DES. And the expansion tolerance is also a little bit higher than with other scaffold, which also reduces malapposition and stent thrombosis risk. Degradation is just a hydrolysis into the 2 tyrosine, which are iodinated, a little bit of water, and carbon dioxide, which gets exhaled. And this is renally excreted, and there is no issue with those degradation compounds. So it's also a safe degradation process. And this is the mechanical stability that it actually increases within the first 3 months and then maintains over 6 months until the vessel is stabilized, and then starts resorbing quite quickly. And then after 3 to 4 years, the scaffold seems to be completely resorbed from the vessel. The resorption, as I said, is safe. Here you can see inflammation in endothelial cells. They're calcifying already. Apoptosis happening in the resorption absorbed in a cell media. And on the phantom, you can see that very nice, smooth, and healthy endothelium. And you can also see that in vivo in a pig model with calcification around the struts. These could be potential bad outcomes with inflammation and thrombus activation and then stent thrombosis. Absorption, I believe, and the company believes, is associated with less inflammation, mainly to less polylactic in the tissue. So the pH levels are not dramatically dropping. You can see here with Absorb a high spike of acid lactic in the tissue, whereas Phantom is quite low, and also the inflammation is lower and still resorbs. Strut thicknesses, again, are low, but still remaining enough radial strength in this scaffold. And this is the balancing act with BRS. There is expected a little bit earlier hazard, which we didn't see in an Absorb, but there might be a late benefit, which we didn't see in Absorb in the small vessels. But as soon as the scaffold is completely resorbed, I assume we will get to the MACE rate of a drug-coated balloon vessel, but we might have take into account an early hazard when there is mechanical stability needed in a vessel treated. And this is how it looks in a patient. That's an OCT from a patient at baseline, post-implant. You can appreciate that the struts look different than in the DES. They're transparent. The shadowing behind is much less. They're boxy, like you're familiar with Absorb. But here you see a nice expansion, a nice position, and after 6 months, it's completely endothelialized with a thin layer. And after 5 years, complete absorption, you see this golden ring, and also the area, cross-section area, can now grow because the vessel has compliance again. There's no caging, and you can appreciate that this is a very nice result. And this is one pullback. So just that you also see a moving image. This is the distality. And then you can appreciate that at some points here, there might be some reminiscing struts. Here you can appreciate that there are some bumps that are still pieces of this tyrocore, polycarbonate tyrosine. But overall, 99% of the scaffold is resorbed. And we have a very nice result. Clinical data to the end, there's a few studies going on. It's difficult to recruit patients because they have to be non-bifurcations. They cannot be big vessels like 5.0 and heavily calcified. And you can see that there is a lot of collaborations worldwide. So it's an international multi-center trial program from Riva and B. Brown. And what we have here in the Phantom 2 trial, cohort A and B, now presented exactly a year ago, the EuroPCR, the 60-month data in 240 patients, and it shows consistently low MACE rates even after 5 years. So when you look here, we have an increase of MACE early, so between 6 months and 12 months, it went up to 4%, and then from 12 months to 60 months, only 2.1% more. So it's actually flattening out, and it resembles the curve that I showed before with early risk and then late benefit. And knowing that this scaffold is fully resorbed after the 4th year, so we expect that this line is now leveling out and not increasing 2% to 3% per year like in drug-eluting stents. This is also results from Phantom 2 trial in target lesion failure, and you can see that after 5 years, TLF is actually very low, 5.8%, and compared to the Absorb, it's completely a different animal. And I showed you before from the characteristics, mechanical and biological characteristics, that this might explain this huge difference here. So it's very promising scaffold and also very promising polymer. Definite stent thrombosis is always a risk in early underexpanded and malopose devices. But you can see here, again, 36 months and 60 months, there is 0 acute stent thrombosis. There was a subacute in a patient that discontinued DAPT very early. But overall, it looks like, at least in these simpler lesions, a very safe device. And then also we have a post-market registry, 24 months follow-up of the first 100 patients. And you can see here, TLF rate is really low, in hospital 0, and then after 2 years, 1%. And also the acute stent thrombosis rate is 0, so there were none of early problems. In conclusion, Thyrocore is a differentiated polymer for vascular scaffolds. Phantom offers substantial improvements over first-generation BRS, reduced strut thicknesses, increased radial strength, radiopacity, improved ease of use, and improved vessel healing. Almost too good to be true, but it's actually there in this scaffold, and I appreciate that every day in my daily practice. Thyrocore strength is strong, is biocompatible, safety profile is really high, and preclinical and clinical studies are on the way. So with that, I want to thank you and open up the discussion.
So please, colleagues, come out with questions about, also this promising technology. I had a chance of trying it in some patients a few years ago, and it went very well. Implantation was easy, and the outcome was very good. And I have to also say another thing, that the slide where you show with the latest generation, the curve of degradation according also to maintenance of the radial strength is very impressive. There is an increase in radial strength for the first 3 to 4 months, and then it stays there for the following months and then goes down. This is very, very impressive. My question is a little bit more harsh. So what should this company and eventually other companies working on the field should do in the next few years in order to not to repeat the mistakes done previously and to give some more fuel to this technology?
Very good point. Thank you very much. I mean, this is exactly what Riva and B. Brown are doing, and that's why I've shown you we have so little patients in these trials, because the inclusion rate is really, really low. Because a lot of exclusion criteria are there in the beginning. All the risks that we know could threaten a BRS technology are excluded, like left main, bifurcations, heavily calcified lesion, long lesions, tortuosity. And I think this is a really good idea to restart safely. It's also difficult to recruit centers, mainly due to the guidelines, because they're really strict. You're almost convicted if you implant the BRS, and so I had a hard time to find centers to participate in the post-market trial. But still, I have to congratulate the two companies to persist over all these years, and it's really expensive to do that, and it's labor intensive, but they keep going, and I think due to that we have this very promising good results. And on that first brick, we can then put the next one, and we gradually have to work us back into the guidelines, hopefully. Absorb had it easier because it was the first one. It was a hype. Everybody jumped on it. And I also think that this was at the end the downside, and it ended up in these bad results.
So there are a couple of questions online I would like to address to you. The first one is, what is the optimal duration of DAPT after scaffolds? And the second one is imaging mandatory at this point?
It is not mandatory in the post-market trial, but we strongly recommend it. But it's usually the case in trials you cannot make it mandatory, then you wouldn't find any center to do it. But it's highly suggested, and the rate of imaging is around 80%, so it's really high. And the DAPT duration in the trial is equal to DES. It's not according to the recommendations in the guidelines, which are basically indeterminable, which is, I think, not a good recommendation because you're not considering the continuous and increasing bleeding risk. So at one point, you create more bleedings in these patients, then they benefit from a prolonged STAPT.
So is it 6 months in stable?
Yes.
Yeah. So
You have a second question, you said, from the audience?
well, he already responded. Imaging part it's recommended but not mandatory.
Okay, so if there are any questions from the audience, there's a microphone. If not, I think the session is over in 46 seconds, and it's my pleasure to thank the speakers for these excellent talks. And I think we put the idea together, leave nothing behind if possible, but in some occasions we need to leave something behind, and if then the, BRS might be advisable. Thank you very much for your interest, and have a good day. Have a great PCR.
Thanks.